Dr. Redick, thank you so much for taking time out of your very busy schedule to spend some time with me and in some ways with our new menopause group, who I will be sharing this with. I just want to take a few minutes to just to introduce you. Um, you are on the faculty of the OBGYN group here at UVA, and you're also, there's a mouthful here, but you might need to help me, a certified menopause practitioner.
That's correct. And, it is something most OBGYNs take care of women throughout the lifetime, including menopause. But just like there are certain specialty areas, like some folks do high risk obstetrics or infertility or GYN oncology, within sort of general OBGYN and within more specifically gynecology, a lot of folks have just taken an interest and developed a little expertise for menopause. Uh, a lot of times the transition is that as you are in your practice and you take care of women, first you get to kind of have babies with them, and then they grow, they get a little older, they get past the baby stage, and then poof, all these folks that you've known for a lifetime and taken care of are now entering menopause. And so it
Wow.
sort of is um, a common spot for people as I'll politely say I've been in practice for 20 plus years. So as you reach that third decade of practice, you find you want to be able to take good care of your patients. So you want to get a little extra training in that area.
Well, thank you so much because, um, you know, there's a lot of interest in this topic these days, and
Mhm.
I wonder what your thoughts are. It just seems like menopause has become sort of a big term lately. Um,
Yeah, yeah, I do think menopause definitely is having its moment in the sun, which is well earned because if you live long enough, every woman will transition through menopause. And so it makes sense that we talk more about it, that we manage the symptoms. I think for many decades, people just sort of their doc said, "Oh, this will pass," and they got kind of shooed out the door, and women suffered and didn't really have the opportunity to address it. Now, I do want to be careful because menopause for some people is a beautiful and joyous moment, right? Like
right.
you don't have periods, you don't have PMS, you don't have to worry about birth control. You have reached a point in your life, maybe where your career is really successful. Maybe your kids are out of the house and you have new amount of time that you never had before. It can be just an amazing moment of time and people enjoy it. And yet I feel like when we talk about menopause, people immediately go to all the negatives, right? So I want to make sure that people see that there's joy to both. Just like aging. I feel like everyone's like, I don't want to get old. And yet there is still a lot of silver lining to having some age and wisdom under your belt.
Absolutely. Yeah, it's so true. And I love how you're taking that other spin on it. Because I think this is an opportunity for women to pause and maybe reflect on their self-care and what is going on with them. What are some areas that they'd like to work on? Um, can you take just a minute just to share what is menopause?
Yeah. So the definition of menopause is when you have gone a full year without a menstrual cycle. Now, as you might imagine, that's a retrospective diagnosis, right? So you're going to have experienced all of the symptoms of menopause before you can officially say that you are postmenopausal. And so I think we know that there's a common transition that people have. Some people call it kind of perimenopause. That may start 10 years before you finally stop your periods, right? And that might be your cycles. I have so many women come in and used to be like, I knew exactly when my period was going to start. It was 28 days, and now it's 25 or 31. And you'll start to have more cycle variation. You may have the actual volume of your cycles change. You may experience a little more sort of PMS and mood symptoms. These are subtle, and so a lot of people just kind of continue life and don't realize that maybe these are subtle changes. And then people do get bigger changes. They skip months. They start to have night sweats and hot flashes. And then they're like, huh, that's when it sort of clicks in. Now, sometimes they also do a couple pregnancy tests because they missed their period, right? Or I've had people like see the cardiologist because they were feeling hot and their heart was pounding and they thought maybe they were having palpitations. And then they sort of figured out, oh, wait, this is perimenopause.
Yeah. Well, thank you. It sounds like they're varying symptoms, right? And like you said, some people can kind of get through this period and of time and feel like they didn't struggle so much. And then you hear others that feel like, things are really falling apart for them. Are there any other symptoms maybe worth noting that you hear about?
Yeah. So I think part of part of the process is to make sure that these are the normal, quote, quote, normal expected symptoms of menopause, and do indeed make sure you're not missing something because you can have heart arrhythmias causing your
Right.
palpitations,
Right.
not menopause. You could have thyroid disease, and that's why you feel tired and fatigued, and your hair feels, different, or your skin is more dry. Y- and so I think we do spend a little time really asking those questions, getting menstrual history, finding what the symptoms are to make sure we're not missing something else. But to answer the original question, which is what are the common symptoms? So folks who come in to me, obviously are the ones who are having the most severe complaints. Because if you don't have a problem, you wouldn't necessarily be coming in to talk about menopause. But vasomotor symptoms are what really bring a lot of people in for treatment. And these are those, that what people describe, like, feeling like someone turned a fireplace on inside and, and I say like this because many people describe it like just flushing up their body. This happens multiple times during the day. It distracts them. They're maybe in the middle of a presentation at work and this happens and they feel mortified because their face turns red. It's not like you can sort of just pretend it didn't happen. People see the perspiration on their forehead. Um, and then night sweats and it wakes people up and that chronic waking up all the time contributes to just not feeling well during the day, feeling fatigue. So those vasomotor symptoms, daytime, nighttime, are what people complain about the most. One thing, and I'll make sure to say it here, that a patient promise that I would tell people is that even if for whatever reason you don't tolerate treatment or can't take treatment, almost everybody gets better, right? Even even if you never start a medicine, you don't go see the doctor, the vast majority of folks, these hot flashes, these night sweats, very quickly taper off, usually within, months, but maybe, 1 to 2 years. Now, while you're in the midst of it, and it's, that's not very reassuring. And so we do have ways to treat it. But I think she said that was just wanted me to make sure that whenever I saw patients that I said that this is something that with time will get better. Now, we do know, and this is sort of unfair, is that if you are someone who has very severe hot flashes, you're probably going to keep them longer. And so if you're that person with mild symptoms, it probably is going to stay mild. It might have something to do with the way our thermoregulatory zone is and individual to individual. But there's definitely some data to say those that get it early and severe keep them longer.
Oh, well, thank you. Um, and thank your friend or patient who asked you to mention that because that's hopeful too. What about, can you spend a little time on treatment?
Yeah. And, I realized I talked just about vasomotor symptoms. There are lots of other things that people experience during that time that obviously impacts treatment choices. What the symptoms that you have sort of help us decide what you need the most. So in addition to vasomotor, I do see a lot of mood. And I've heard, I've heard a lot of things, but the most common ones are sort of this almost like PMS, like irritability, just short-tempered. But we do see increase in anxiety and depression during this time, and particularly if you already had some pre-existing concerns, this can sort of like kind of turn the volume up on it a little bit. So vasomotor symptoms, food. We do see a lot of people describe this brain fog, and it's hard to know, is it sleep related? right? Because if you're not sleeping well, you're probably tired, fatigued, not concentrating, thinking well. But there are some you know, very elegant studies that talk about how estrogen affects different parts of the brain. And there is this sort of word finding thought that seems to be more prominent in people who are transitioning through. So like if you're struggling to come up with that word, that is a very common complaint. The other is weight. I feel like in general, as we age, we see weight gain, but we particularly see a redistribution, so you sort of get this middle. A lot of people describe like, oh my gosh, like I had this new belly that I've never had before. And we do see a little bit of that with menopause. Unfortunately, giving hormones back is not magical. And I know you'll get to talk a little bit about ways to address healthy eating and weight, but I definitely hear that concern. So vasomotor symptoms, mood, weight, and then as a gynecologist, I do talk a lot about sexual health, and so vaginal symptoms and other things related around interest and sexual health come up as well.
Oh, thank you. Any particular thing about bone health?
Oh, thank you. Yeah. So we know that when you're sort of building bone density, you do most of that through your early, up into early adulthood, probably, 30, 35. You hold fairly steady. And then when you transition through menopause, we see relatively rapid bone loss, and then it sort of levels out. Um, there are a lot of factors that um, affect where your bone density is when you're at your peak bone density. And so some people come to the game maybe from a family history perspective that their bones aren't as dense, or they've had conditions in their lifetime that have probably impacted. So thyroid, having to take steroids for something else, such that when they arrive at menopause, they're already a little bit lower. Currently, the guidelines recommend bone density screening at 65. That's for someone with no risk factors, men and women. Having a risk factor might prompt you to get early bone density study. And menopause, particularly early menopause, so average age of menopause is around 50. But if you have menopause much earlier than that, that might be an indication for early bone density. A family history, a fracture that doesn't make sense, right? Like you fell at ground level.
Mhm.
Um, we know that weight-bearing exercises, vitamin D, these things help protect you from bone loss. We do know that menopausal hormone therapy can help slow that rate of bone loss, but it alone should not be the reason to take menopausal hormone therapy because we have lots of non-hormonal ways that we can help treat bone density. Prevention is the key. So get your calcium, get your vitamin D in your diet, walk, exercise, building your bone density when you're younger, right? So interestingly, maybe we should be talking to our 18 to 20-year-olds and making sure they eat healthy so that they get nice, healthy bones.
Great. And thank you for that. And then with heart health, is there an increase due to the lower estrogen with heart health?
So this is the quick answer is that heart disease increases with age, right? We know that, so that means that women are in menopause and older have more, heart events than younger women.
Okay.
We also know that estrogen can be a thrombogenic agent. So that means that it could put you at risk for blood clots, like in your leg, in your lungs. And so if you have a predisposition toward clots, maybe you had one before, maybe you have a family history, then you do have to be really cautious about providing menopausal hormone therapy, right? For folks who are low risk, don't have pre-existing, there's some data on both sides of this about giving estrogen early could be protective for the heart. Whereas if you give it later, if you already have like plaques and other things in your heart, and then you take estrogen, it might actually increase your risk.
Okay.
And the reason I say there's kind of data on either side, the Women's Health Initiative, which many people remember came out in the early 2000s, that study was done on women who had no symptoms. Because at the time we thought estrogen was going to help prevent heart disease, it was going to help prevent bone problems. It was going to be like if we gave every woman whether they had symptoms or not, they would benefit. And what we found is that when we gave estrogen and progesterone together, that we had more adverse events in the women taking estrogen and progesterone than the women who didn't. Those adverse events were pretty small difference. So just to kind of put it in perspective, if you gave 10,000 women the estrogen progesterone, you compared them to 10,000 women who didn't. In a year's time, 10 to 12 more adverse events would occur in that 10,000 women. Now, if you're given a medicine purely for prevention, that doesn't make sense. If you're given that medicine to treat hot flashes, that's a pretty safe medicine, right? So our guidelines are kind of centered around the idea that if it is for treatment, then it makes sense. The other thing that people looked at that study afterward is that the number of adverse events was very related to age. So if you had just transitioned into menopause, that number was much lower, right? Like that, 10 to 12. Whereas as you got older in your 60s or your 70s, the number went up, right? Up to maybe 35 to 40 per 10,000. The other thing about that study that is that they had two arms. They had one with estrogen and progesterone, one with just estrogen. So if you have a uterus, you have to give progesterone to protect the lining from that chronic exposure to estrogen. The folks who were in the estrogen only arm actually did have fewer adverse events, and they actually let that part of the study run because it looked like it was protective, right? And so you've got to figure out like, well, I've got one arm estrogen progesterone and one arm estrogen, one didn't help and one did. Does that, and that leads to us, this is where having a personalized discussion about you helps you decide what is the right choice for me. You think about what's my cardiovascular risk, what's my breast cancer risk, what are my symptoms, what dose is best for me. These are all things that need to be sort of personalized for each person, for the patient when they come in.
It makes sense completely. So basically, just have a conversation
Mhm.
with your provider and determine what is best for you.
Right. And this is just one small part. I think one thing that I really emphasize to people is optimizing your health, your general health is going to help you transition through menopause as much as anything. So, getting a good night's sleep, exercise, eating well. I sort of, my patients probably kind of laugh at me. But I say, remember what your grandmother told you? Like, get a good night's sleep and eat your vegetables. Like, all of that still applies and makes a difference. People feel better when they get a good night's sleep, they exercise. And I know you talk a lot more about it. I usually put this into three categories: exercise, and I'm careful to talk about movement. So, you want to be active. If you're thinking about cardiovascular health, you really do want to push that high intensity, heart pumping, but it doesn't have to be long. Even 15 to 20 minutes of raising your heart rate, done, you have to do it multiple times per week, but 15, 20 minutes, you can just like, power walk and get your heart rate up, right?
Right.
Um, and then for women, we don't do probably as good a job as our our male companions in weight bearing and resistance and weight training. So really getting that once or twice a week, something that's sort of like a little more resistance training. And then the other thing that I also talk about is stretching, flexibility, and sort of mind calming exercises. Like to me, I think about putting that in the same category. You can't do all that in one day. That's too much. That's too much. I talk about like trying to pick something each day so that at the end of the week, you've done your different types of exercise and movement. It's got
I
to be,
love it.
yeah,
Thank you. Thank
it's
you.
got to be fun too, right? Like,
Right.
so
And
walk with a
starting
friend.
exactly, make it more fun and picking something that you enjoy and starting where you are.
Yes.
Haven't been exercising, start with just 10 minutes and build up
Yeah.
to what's recommended.
And I think I hear a lot of people like, I try to go to the gym. Like, you can do all of this without ever setting foot in a gym. That some people love it. I belong to a gym. It motivates me. I have people who expect me to arrive at a certain time, even when I don't want to, but it helps me get
Right?
there. Um, And so everybody, I think finding something that works. And one of the things that we talk about is healthy habits. Like just if it's what you do every day, then that's a lot easier than sort of like feeling like you're having to lift above sort of your normal levels.
Great, thank you. Well, you've shared some things that we can all do, like I say, on our own, just taking good care of ourselves. This is an opportunity to go, hey, I still have life left, and I want to, enjoy it and hope that we will all remember that it's not the end. And so I like how you did emphasize the lifestyle and even starting as soon as you can. And like you mentioned earlier, that these symptoms get better for most of us over time, and
Yeah.
so they won't go on
Yeah.
forever.
And, I think there are a lot of, when people think menopausal therapy, they immediately think hormones, but there are a lot of other treatment options that aren't hormones that can be tailored to people's symptoms. And there are some FDA approved products. So just to say them out loud so that you have them on the recording. But one, um, the paroxetine, it's also called Paxil, at a 7.5 milligram dose called Brisdel has been shown to help with hot flashes. Maybe a nice choice if people have a lot of mood symptoms. We use off-label some blood pressure medicines, Effexor, other SSRIs used for anxiety and depression. If people are having a lot of anxiety symptoms, sometimes that can be helpful. And then the most recent thing on the market is the Veosia, which is the brand name for, and I can never say Visavigilant, um, but it works. It is a neurokinin B2 receptor antagonist. So when your estrogen goes away, there's receptors that sort of kind of pop up in the thermoregulatory zone. And we think that's what's the trigger for hot flashes. And so this medicine kind of soothes that. So it's a great treatment for hot flashes, but it doesn't really treat a lot of those other symptoms. But for folks who can't take estrogen or don't tolerate estrogen, we definitely have some options that are out there and available. So when we talk about menopausal hormone therapy, it is typically estrogen, progesterone. There are at times that we talk about testosterone, but that again is very personalized for each person.
Great, thank you. Um, I wanted just to follow up on one thing you mentioned earlier, um, about maybe some sexual discomfort. And are there creams available for that?
Yeah. So I put these into categories. So and I also usually ask a little more details about symptoms. So if people are having dryness, itching, and irritation all the time, then you do want to make sure that someone doesn't have a dermatologic condition. They don't have contact dermatitis. You may, and dermatologic conditions can be things like lichen sclerosis or lichen planus. And these are serious and need to be treated. And, I've, we can typically diagnose them with just a physical exam, right? So we can look. Sometimes we have to do a biopsy, but you want to make sure you're not missing anything. But that's kind of dryness all the time. Then some people are like, well, I'm generally okay except sex, right?
Right.
So if most of the pain is with intercourse, and to be honest, that's a common complaint, and it is typically with I was supposed to say I don't know if we need edit if we need to hit the adult content button right now, but here we are. And I think as a gynecologist, I like jump right into this and don't think about it. But here's the warning for anybody who's watching. Um, it is typically penetration that people have that dryness. So external stimulation, doesn't seem to do it, but that's what kind of is the trigger. If that's the main thing, I go three things. So first is you start with a lubricant for sex, water-based. I would say no warming gels, no flavors. There's lots of products out there. It doesn't require a prescription. Apply early, apply often. And sometimes that's all you need if that's when you're having the pain. If people are having, if that's not sufficient and or they're having dryness outside of that, then we talk about a non-hormonal vaginal moisturizer. This comes in lots of options. Some of them have the hyaluronic acid, same stuff that you put on your face, right, to pull moisture in. That can be really helpful. That's schedule. That's not related to intercourse. So moisturizers and lubricants. That doesn't require seeing a doctor. You can do all that on your own. If those are not sufficient, then we do talk about for folks replacing the estrogen, vaginal estrogen. So this doesn't go through the whole body. So all those concerns about how it affects your heart, your breasts, all of that doesn't apply when it's topical. Now, most folks have this dryness when they're 3 to 5 years plus out through menopause. It doesn't usually happen right away. So we're usually talking about vaginal estrogen later in that menopausal kind of experience. It does take several months for vaginal estrogen to really become fully effective. So you also, I feel like I'm always being like, trust me, hang in there, give it 2 or 3 months, and then folks start to feel better. So it's sort of a three, when you ask creams, I was like, well, I've got 1, 2, 3, right? Lubricant, moisturizer, vaginal estrogen can all make a difference.
Okay, well, thank you. Thank you. This has been really helpful. Any other thoughts? Um, we
I
talked.
feel like I should turn it back to you, right? Because
Yeah.
we've already talked about how so much of negotiating menopause is about those healthy habits. And so, maybe I should get a little information from you, like what what's your best coaching? What's your trick? What's the thing that kind of helped the most when you think about um, diet, exercise, lifestyle, um, and making it through menopause?
I mean, I think what what I have found to be helpful for myself and for others that I work with is movement, movement, movement. And it doesn't, ideally be great if it's structured exercise, but it's also just the day-to-day activity. Because I think so many of us are at a desk and
Mm-hmm.
that's not helping us for many reasons. But I think just the movement and just how it, impacts the way we feel, it does help us to reduce stress.
You made me realize, let me put my standing desk on. Let's go together. Here
All
we
right.
go.
Uh-oh. She's doing
There we go. All right. Now
Yeah,
we can move together.
yeah, yeah. Well, actually, I do these 10-minute micro breaks throughout the week and have people join me. So that's the rationale behind it, is just to move. And I think just taking this time to take care of ourselves, right? It's an
Mhm,
opportunity. And as women, we need to take care of ourselves. We are worth it. And
mhm,
knowing that we're in this together and there
mhm,
are things that we can do to reduce the symptoms. I think laughing a little bit helps sometimes, not taking life so seriously. And there is hope.
mhm.
And we have Dr. Reddick, so,
Well, and I'm smiling because I think most of the people that we're talking to with this session are folks who work here, right?
right.
And so one
It's our
thing,
UPA family.
yeah, and I feel like if you're in the healthcare profession, you almost universally have this sense of giving and sacrifice, and you always put other people's needs in front of your own. I think women as moms and spouses do that too, and this is one of those times where you're going to be a better employee if you take that 5 minutes to refresh, if you make sure you eat lunch, if you go to the bathroom and don't have like wait an extra 30 minutes when you really need to go. Like these sound silly, but um, I made a promise to myself that I would try to walk 5 minutes at lunch, right? Like that seems like not that hard to do, but it has really helped me reset. Whereas if you work, you just keep working. Um, I just don't feel like I'm there for my patients as well. So I hope maybe as it sounds like when people say, I don't know if you have this feeling, but when I hear self-care, I'm just like, oh, like, um, but if you maybe we find a different term for it where I don't run away from it. But I think if we took as good a care of ourselves as we do of our patients, we'd all feel better.
That's right. And a little self-compassion, maybe, realizing that, we're doing the best we can
Mhm.
and, just be reasonable with the expectations of what we can do. And I love how you break down, you said earlier, aerobic, and then maybe some strength, and then some stress management techniques. But
Mm.
we don't have to do all in one day, but spread them out so we're at least
Yeah.
attended to each of them.
Yeah.
And so, yes.
All right. Well,
Well,
this has been lovely. I am looking forward to catching the back end of this group
yes,
and
yes,
seeing if there's questions.
that's perfect. And I'll make sure that you have the Zoom link that they were, for that last day. It's just one link for all classes. And we look forward to seeing you again. Thank
All
you
right.
so much.
Sounds good.
Bye.